Thanks, Bobby. I'm going to have Adam do the formal introduction, but I really just wanted to thank Dr. Qureshi for coming down. And we've known each other for a long time. He's a colleague to all of us and a friend of the division. I would love to have done this in person, to maybe had that night before with the fellows and the residents, and then maybe taking you over to the Orthopedic Center or the Musculoskeletal Center that Dr. Chabra's sort of vision that's going on, but maybe next year. And Adam, if you would do the introductions and the talks, that'd be great.
Yeah. Thanks, Dr. Chabra and Dr. Shen. It's really a great pleasure, not only myself, but the department and the University of Virginia to welcome Sheeraz Qureshi to Orthopedic Grand Rounds this morning. Sheeraz and I are contemporaries. He finished fellowship, I believe, 1 year before me. Yeah. With Henry Bowman up at Case Western with one of my good friends, Paul Goss. But he graduated from Rutgers University and then went on to Tufts to get his MD and MBA. He's an associate professor at Weill Cornell Medical College and Hospital Special Surgeries. He's the Patty and J. Baker Chair in Minimally Invasive Spine Surgery. He probably did a discectomy on Patty Baker and became the chair. And they think he's amazing. It's just a discectomy on a very wealthy New York socialite. He's a research director for the spine division. He's extensively funded by CSRS, NAS, OREF, and NIH. He's had over 170 peer-reviewed publications, over 20 book chapters. Frank and I and Sheeraz were just talking. He's on innumerable committees and in leadership positions, both nationally and internationally. And really, Sheeraz is not only a great surgeon, great guy, but really, I think, extensively recognized as a real thought leader in minimally invasive spine surgery. So we're excited to hear him give a couple talks on cervical dysarthroplasty and also his learning journey doing minimally invasive transforaminal lumbar interbody fusions. And I think this is really important just as spine moves out of the inpatient only setting into more opportunities for outpatients. So curious to ask him a few questions on his thoughts on that, but I won't take any more time. Thanks, Sheeraz, and take it away.
Thank you so much. I really appreciate it. I'm so excited to be here. I think of all the things that we do, being involved in being able to be part of visiting professor programs is really the best part of what we get to do. Getting to connect with old friends and seeing new places. So, Adam and I and Frank and I were talking about how great it is to be able to have some things over Zoom, but certainly these are the things that it's great to do over Zoom, but looking forward at some point to being able to come down and have you guys this way as well. So, but thank you so much for having me. So I will share my screen here. Can you guys see my screen okay?
Yes.
Okay.
Good shape, Sheeraz. Thanks.
All right, great. Thank you. All right, so my first talk this morning, as Adam mentioned, is going to be about cervical disc replacement surgery. It's a surgery, that I really enjoy doing, and I would say that amongst all of my disclosures, the relevant one is that if I needed a single level cervical surgery done, I would choose a cervical disc replacement. So I'm going to put that out front there so that you guys can know my biases. I did my spine fellowship with Henry Bowman, and anytime I give a talk on minimally invasive surgery or motion sparing surgery, I always wonder what Dr. Bowman would think, and whether he's turning over at his grave hearing me talk about this stuff. And so I was a little, worried about, what Adam and Frank would think about me as well. But I had reached out to the fellows ahead of time, and I saw that Adam's practice was about 2% deformity, but he was doing a lot of fusions for lumbar back pain, some disc replacement for primary disc herniations, which I thought was interesting, X-stops for tumor surgery, and even some coccygectomies made up his practice. and obviously the SI joint fusion.
And I still call myself a deformity surgeon because I do 2%.
Exactly. So I didn't feel so bad. And then I said, well, what about Frank? I hope he doesn't worry. So I looked at some reviews, and Frank, you got great reviews online. This patient was super happy with the laser spine surgery for 9 bulging discs. So I thought that was really great. Adam's reviews were a little lower, but I guess because he kept calling some guy named Vaccaro and trying to figure out what he should do as far as the surgery goes. But so anyway, I didn't feel so bad about some of the things I'm going to be talking about today. So, I thought I'd put that out there up front. But I think let's start with a common case that I think that we all see in our practices. This is a patient who's a mid-30s, almost 40-year-old guy. He's had a short history of not only right upper extremity radiculopathy, but significant weakness in a major muscle group in his dominant arm, a 3 out of 5 in his deltoid bicep. Doesn't have any findings of spinal cord irritation. These are the X-rays that were obtained at the time of presentation that show, pretty good disc space height at all of the levels, good lordosis. We can see a little bit of retrolisthesis of C4 on C5 to maybe indicate that there could be some disc pathology in this patient despite his good disc height. You can see he's got good flexion and extension. And the MRIs on the parasagittal views show this right-sided disc fragment at C4, C5. Here are the axial views across the C4-5 level. And we can see on the right side a disc herniation that's posterolateral, abutting the right side of the cord, but really not causing any cord deformation or displacement, but really, impinging upon the right C5 nerve root. So if we think about that patient and we think about the different treatment options, anytime you have a patient with cervical radiculopathy, you think about sort of doing nothing, giving them time, giving them anti-inflammatories, maybe a selective nerve block or surgery. And certainly if we thought about the cheapest treatment, it would be, sort of some Advil and give it time. But in a patient who's got a weakness of the dominant arm, that may not be the best option. This is a study that's almost, going to be 20 years old in a few years, but cervical spine issues are very common. We need to consider them as part of the pie of medical care because they tend not to be so cheap, and there are multiple different treatment options. And if we want to think about the ones that we can have the greatest impact on and provide care for, we have to sort of defend why our options may be better than others in some cases. And when we're thinking about cervical degenerative disorders, we're not talking about this kind of a patient, right? This is the multi-level cervical myelopathy patient that we'd all agree needs surgery. We're really talking about this patient, the single-level cervical disc herniation with symptoms that are ongoing, that are sort of relatively early stages, but some neurologic issues that are having a significant disability on the patient. That's the patient we're talking about. This is the problem we're talking about. So I'm sure that the residents and fellows on the Zoom today have seen many different treatment options for this same problem. I think this is sort of the tried and true, the gold standard ACDF. Posterior cervical foraminotomy, I think, is an excellent option for single level cervical disc disease. And then there's the cervical disc replacement surgery that we're going to focus on today. But these are really, from a surgical perspective, the 3 options. We had looked at sort of just the current trends in treatment for single level cervical radiculopathy. And it's interesting, as you'll see in a lot of the studies that I'm going to talk about, the comparator is always ACDF and cervical disc replacement. But as I think Frank and Adam might agree, when we think about the patients that are good candidates for cervical disc arthroplasty, they're also often could be potentially candidates for a posterior cervical foraminotomy. And what we found was that actually the trends in usage of ACDF are not changing, but as CDR utilization increases, the biggest impact it's had is on cervical foraminotomy, which in some ways may be a cheaper and perhaps better alternative, although I think that that's still yet to be proven. So there are many different types of cervical disc replacements. I would say this is probably, this one that we're showing here is the Mobi-C implant. It's a unconstrained implant, very easy to put in, and probably the most commonly one used today. I have actually gone away from this, as I will get into later on. This is another type of implant. This is a more constrained implant that's put into place and has 4 keels that go into the vertebra, so provide a little bit more stability. It's a metal-on-metal implant as opposed to the one that we showed before, which is a poly implant with metal. So there are differences amongst the different types of implants. So we're going to be talking about cervical disc replacement in general, but I think like in any joint replacement or disc replacement conversation, there is some tribology that we certainly don't know enough about when it comes to disc arthroplasty in terms of the differences in the different types of implants, and that's certainly an area that still needs to be better studied. There are a lot of articles that have been published on cervical disc replacement, and I would say important for the residents and the fellows on the call to know that cervical disc replacement may be the absolute best thing that's been studied in spine surgery. There have been multiple IDE studies, prospective randomized studies, tons of patients with long-term follow-up. And I just wanted to take the beginning of this lecture to sort of go over the different studies that have been done and what they've all shown. So this is just a listing of the different FDA-approved implants, some of which aren't even used anymore. The Bryan disc is not used anymore. I think the Prestige ST is not used anymore, and it's just because companies have made different decisions. But these are, at least at the time that I put the majority of this talk together, were the main FDA-approved discs. Since then, I think at least one more has been approved. And if we look at the prospective randomized studies at the time, just amongst these disc replacement implants, you can see that thousands of patients have been looked at over the long term. The inclusion and exclusion criteria for these different IDE studies are extremely similar, which is why I think, although I will present them separately, it is in a lot of ways safe to be able to lump these studies together to look at them in aggregate, because they used very similar criteria, both for inclusion and exclusion. And the control in all of the cases was sort of what we would all consider as the gold standard, the ACDF, most commonly with plate and bone graft. In order to have success in these IDE studies, the outcomes that were looked at, both primary and secondary, are listed here. And for overall success, you had to meet all of the criteria. So that was pretty critical, especially I think in the NDI, which is the Neck Disability Index criteria. You had to meet the parameters of success for improvement. So if you look at this, if you had a 14-point improvement in your NDI, you were not considered to be an overall success. So you had to meet these criteria, which is what I think, again, adds a little bit to how powerful these studies can be. And if we go into the specific studies, I think this was the first one that was published looking at the Bryan disc. And I won't spend a lot of time on the specifics of the studies, but really, you know, the important things to highlight here, if you look at the 2-year follow-up in these studies, both in the study arm and the control arm, you can see, you know, 95% and almost 90% retention in terms of 2-year follow-up, and you can look at the overall success on both sides being very significant of fusion and disc replacement, but that disc replacement outperforming at 2 years in this study. This is a different implant, but again, one of the earliest implants available. I think this was actually the first implant that was on the market. The Prestige showed excellent results compared to ACDF at 24 months, where there was statistical superiority. Same thing with this implant, which is the ProDisc. Again, subtle differences in these implants, but you can see that the overall outcomes in all of these studies were quite similar at the 2-year mark. And these were all prospective, randomized controlled studies. As we got a little bit further out, or we started to think about saying, okay, well, what about 2 levels? So this was an important study that was published looking at 2-level cervical disc replacement, looking at 330 patients with, again, randomized, and showed that, again, cervical disc replacement, even at 2 levels, maintains statistical superiority over ACDF at the 2-year mark. This was 4-year data. So initially it was 1 level at 2 years, then it was 1 level looking out multiple years, then it was 2 levels looking at 2 years. So really kind of build the literature building upon itself to look at, multiple year results. These are 5-year results of the randomized controlled trials, and then even out to 7-year results. And you can see that the outcomes, of overall success and improvement in those categories that defined overall success were maintained and were superior in appropriately indicated cases for cervical disc arthroplasty, both at 1 or 2 levels. So I use that just to sort of build the case that I would say that there is level 1 evidence to suggest that cervical disc replacement is an appropriate treatment for a patient with a single level cervical radiculopathy, the case that we made earlier. So I think that, when we say that there's level 1 evidence, I think all of those studies would also show that there's level 1 evidence that ACDF is an appropriate treatment as well. And so the surgeon's task in a scenario like this, and sorry for the background noise, but the surgeon's task in a problem like this, when you've got multiple good options for treatment, which include non-surgical and surgical options, is to try to figure out which procedure is going to result in the best outcome for the patient that you are dealing with that's in front of you. I always say that percentages and options are for everybody else, but for any one patient, there's usually one best option, and there's going to be one outcome. It's going to be either bad or it's going to be good. It's pretty binary. So we have to consider sort of the cost of healthcare when we think about these things, because as we all know, healthcare is expensive in this country. And there's a little bit of an alignment issue, because I would say that the goal of healthcare is not just to figure out the lowest cost treatment. It's really to find the treatment that allows for the best value. And so we have to think about cost, we have to think about cost effectiveness, and then ultimately we have to think about value. And so when we're thinking about value, again, I think this particular topic really highlights, at least for spine surgery, what we're talking about, because it is an indication and a pathology that can be treated potentially non-operatively, often operatively, and there are multiple good options. So when we're thinking about sort of value, and think about what the goalposts sort of around which we define really good outcomes, and maybe in any particular patient, which option provides the most value. So this is just sort of how value is defined. I'm sure everybody on this call is familiar with these terms, but we're really thinking about quality, cost, and time as being the key factors. And so those studies that were done that I presented, I think highlight quality. They highlight time because they're followed over a period, but they don't necessarily highlight cost. And so cost effectiveness can be very important when we're thinking about a topic such as this, and specifically around cervical disc replacement, because cost effectiveness or cost utility is really probably in this scenario becomes very important, because you are comparing really good options for a particular problem that can be extremely variable in terms of their cost. So we've spent a lot of our time looking at cost effectiveness around cervical degenerative disorders, but really specifically around cervical disc replacement. This was just a systematic review that was published several years ago now, that I was involved with, looking at cost effectiveness in different cervical degenerative diseases. And what we found was that there's probably no full economic evaluations, and I think that this still holds true, although this paper is from 2014, that actually look at the economics of operative versus non-operative management for cervical disc disease. I think most of us use clinical judgment on who's a surgical candidate and who isn't. But in terms of the economics of this, they're not still very well understood. What we found in this study, though, was that for at least for surgical treatment, and I'll just highlight the part that's relevant to this talk, that cervical disc replacement may be more cost-effective than ACDF for the treatment of cervical radiculopathy at one level. We also found that posterior cervical foraminotomy may be more cost-effective than ACDF, at least out to 2 years for the same problem. So our gold standard, which is an excellent surgery, and often, again, you have to take everything that I'm saying with the caveat that there are most patients who present with a single level cervical issue may not be candidates for posterior cervical foraminotomy or disc replacement. So this is sort of that very sort of maybe small, but I think getting bigger subgroup of patients that could be a candidate potentially appropriately for any one of these three options. What we found in our own cost effectiveness studies was that ACDF, in terms of quality adjusted life years, was a little bit more expensive than cervical disc replacement, although both were small numbers when you think about sort of what the actual cost per quality society is willing to spend, which can be upwards of 50 to 100,000. This was early data, this study. When we did similar modeling with 5-year data, what we found were that both, again, are cost effective. And what we found here was that there are sort of parameters around this. So as long as you can keep the cost of disc replacement below 20,000, it can be a dominant strategy. If you can keep your complication rate below 5%, it would be the dominant strategy. But if suddenly the ACDF cost was able to fall below $18,000, it became the dominant strategy. So there are some variables here around cost and around the quality of the surgery that's being done that have an impact on this. We most recently looked at this out to 7 years. And again, we found that, at the further out we get, the more cost effective the surgical treatment of single level cervical radiculopathy, both with disc replacement and ACDF, proved to be. So now we've sort of looked at the data. I would say clinically, we would say that there's level 1 evidence that clinical effectiveness for cervical disc replacement exists. And I think I would say, it's hard to put a level on this, but doing systematic reviews and doing modeling around cost effectiveness, I think that we can also say that not only is cervical disc arthroplasty clinically effective, but it's also a cost-effective option amongst the multiple options that are available for the treatment of single-level cervical disc disease. So I would tell you, in terms of my current decision-making for patients who come in with cervical disc issues, if I see a patient who's got cervical degenerative disease and they've got facet arthropathy that results in a significant amount of neck pain, I will do an ACDF for this patient. I primarily will use an integrated device for this as opposed to a plate and screws. If I have a patient who's got a lateralized disc herniation with no cord abutment, whether or not they've got myelopathy, but I don't like to try to go after a fragment that's close to the cord. But if there's no cord abutment, a lateral disc herniation, and if there's sort of at the level I'm operating on, if there's no kyphosis or minimal kyphosis, I like a posterior cervical foraminotomy for this, and I would say I'm increasingly using foraminotomy. But if there is a patient with 1 level disease, and definitely if there's 2 level disease, there's no facet arthropathy, and the symptoms are as we presented, then the cervical disc arthroplasty for me is my go-to implant. So we'll shift gears now to some of the surgical techniques around cervical disc replacement, because I would say that cervical disc replacement, I think similar to joint replacement and in the hip, the knee, the shoulder, et cetera, elbow, the surgical technique is very important. It is not a forgiving surgery in that sense. And I think some of the outcomes issues that some people can highlight sometimes are because a lot of surgeons were doing cervical disc replacement the same way that they did ACDF, and I can say that that probably can result in less than optimal outcomes. Patient positioning is really important. You do need fluoroscopic visualization for this type of a surgery in both the AP and lateral planes. I've gotten away from AP fluoroscopy intraoperatively now until the end, and I think as most of us get better at cervical disc replacement and do more of them, most of us have probably gotten away from it. But I do think that it's still an important thing. I don't like to leave the OR with a good AP image to make sure that my implant is well positioned. This is an image of a patient that we all worry about, so this is a patient who's got a big neck and big shoulders. C6-7 level that was being operated on can be very challenging to visualize. But there are tips and tricks by, working with the fluoroscopy unit to sort of really cone down on the level of surgery. But it's really important to be able to see both end plates that are involved in the surgery, and you want to be able to see from the front to the back of the disc space, and have a good view, because again, the positioning of the implant it is critical in terms of outcome here. In terms of patient positioning, oftentimes, I'm sure when most of us are doing ACDFs, you guys are probably similar to me. We put a roll under the shoulders to get the neck extended, to be able to have really good room to work. But when we're doing a cervical disc replacement, you really want to avoid a hyperextended or hyperflexed posture. I don't think any of us would really have a hyperflexed posture when we're operating, but hyperextension is not uncommon, and can lead, if you're not thinking about it, to taking off more end plate posteriorly in the disc space, which can ultimately then lead to kyphotic malalignment. These are images that I borrowed from a JAOS article that Jacob Bukowski had published several years ago, sort of just defining how that happens and how you end up taking more end plate posteriorly, and then postoperatively, when the patient starts to weight bear, the weight of the head, you can go into kyphosis because you've taken off more end plate posteriorly, and you haven't properly sized the implant. So neutral positioning of the neck is critical, both for end plate preparation and prosthesis insertion. And you really want to have a neck position that sort of looks like this. It looks fairly straight, and the end plates are pretty parallel. And I've really gotten away from doing any burr work, or trying to at least minimize burr work when I'm doing a cervical disc replacement. Otherwise, it's a pretty standard approach for most spine surgeons. Smith-Robinson approach. There's self-retaining retractors placed. I think most of us would use distraction pins. I certainly do. This is what that looks like. Pin placement can be important here, especially if you're using some implants that involve keels, and especially if you're going at multiple levels, because you don't want to create a stress riser in a keeled implant with multiple pins. So oftentimes I will place my pins a little bit off center and then be thoughtful around the distraction that's occurring to make sure that I'm still providing all my releases around the level of surgery appropriately. At a single level, it's a little bit less important, but I do often try to get the pins for a little further away from the area of the procedure. In terms of decompression, I would say that, again, the cervical disc replacement is a little bit less forgiving when we're thinking about a decompression as compared to an ACDF. I think most of us would say, well, if there's bony osteophytes or uncovertebral osteophytes and we're doing an ACDF, we're going to get a good decompression directly. We're going to rely on an indirect decompression for some parts of it, and ultimately, when the fusion occurs, there is this concept that because the motion is stopped, that there's some resorption of the osteophytes and the symptoms go away. I think because you're preserving motion in the cervical disc replacement, you really have to sort of shift. And I would say that most surgeons who start doing more cervical disc replacements probably do better direct decompressions even for their ACDFs, because you just get more comfortable sort of really going after all of the osteophytes and cleaning out appropriately, not only the central part of the dural sac, but also the foramen bilaterally. removing the disc, I think, is sort of second nature for us. And then identifying the uncovertebral joints is important. And especially as you start to expand your indications a little bit, as I'll talk about in some of the upcoming slides, having an understanding of your uncovertebral joints is very critical because if you start to drill away or bite away your uncovertebral joints and start to lose centering, you can end up with an AP X-ray that shows that you're off to one side or another, even by just a few millimeters, and that positioning could have an impact on the patient's outcomes. As we talked about, it is critical to remove all of the osteophytes, both posteriorly, because we want to get the implant as sort of to get full coverage from front to back as much as possible, and then also out in the foramen, as we talked about. In terms of the foraminotomy, it's sort of a delicate balance. Most of us like to use a burr because it's less traumatic to the nerve root than multiple passes of a kerosene rongeur. But the burr does produce bone dust, and if you're using a burr, you want to make sure that you're irrigating away all the bone dust. Some of the issues around complications that are thought about traditionally for cervical disc replacement are, that the level can fuse. And sometimes it can fuse around those uncovertebral joints if there's been a lot of burr work done, and some of that bone dust has kind of been left behind or not appropriately cleaned out, and the area can fuse or create painful motion. I tend to resect the PLL in, I would say, close to 100% of my cases. There is some thought around implant properties and how constrained an implant is, whether or not you want to maybe maintain some of the PLL. But I generally do resect the PLL. I find that it allows me to balance that disc level a little bit better in terms of having appropriate motion, especially with a more unconstrained implant. I do not, however, do a complete resection of the uncinate, as we sometimes will do for ACDF surgery where there's significant uncovertebral hypertrophy. That it is really important to maintain that lateral checkpoint for your disc arthroplasty implant, both when you're placing it and then for stability afterwards from side to side. Prosthesis sizing, I think, is one of the biggest things, the hurdles that you have to get over when you're doing a cervical disc replacement and are used to doing an ACDF. When we think about ACDF surgery, we think about the fact that we don't want to over distract the facet joints, but we want to get sort of a big enough implant in, or so often as big an implant in as we can get in terms of height without over distracting the facet joints. And we're not as worried in ACDF, at least traditionally, in terms of coverage from anterior to posterior. That is completely reversed in a cervical disc replacement. You do not want to overstuff a cervical disc arthroplasty in terms of height, and you want to get the most coverage in terms of side to side and front to back, so that you could try to get close to producing more normal kinematics around the center of rotation of the disc space. And so, but overstuffing an arthroplasty or putting an arthroplasty that's too small from front to back are the most common things that I see when patients come in with sort of pain after a disc replacement has been done. So implant sizing is really critical, and it does vary from implant to implant. This is the sizing for the Mobi-C implant, but it's just specific to that implant where you have some rotational checks. Some implants do require slots or keels, as we talked about. This is showing a ProDisc implant, which is a single large keel at the top and the bottom. Keels are also involved in other implants. The one that I now most commonly use is called the Prestige LP, and it's got 4 small keels at the top and bottom. I do place this implant, and I do my ACDFs under fluoroscopy as well, again, just to make sure that we are getting full coverage from front to back. And this is just another look at an implant. Once that implant is placed, I think it's important to get an AP fluoroscopy shot in order to make sure that you're not off to one side or the other, and that there are not rotational abnormalities. And this is especially important when you're doing multiple levels, making sure that you have a good AP X-ray that shows good coverage and good rotational placement and positioning are really important. The comment that I made earlier about the uncovertebral osteophytes, I specifically chose this as an AP X-ray because you could see here preoperatively, this patient's primary issues were right-sided around the foramen, and there was some bony changes in the uncovertebral joints. And so it's really important when we're putting in this implant. I like to look at the AP because we want to make sure that we've not only done a direct decompression, but at least somewhat of an indirect decompression. And so when I see this AP shot, I really focus on sort of what the uncovertebral joints look like bilaterally and make sure that they're even and that they're lifted off of each other. Because then I will feel good about when this person is moving, that they're not going to recollapse or still have persistent stenosis in the foramen where the issue was. Standard closure. I don't use bracing after surgery. I also don't use drains for these. I don't use drains for any of my cervical patients at this point. But you do want to get, like with any anterior cervical surgery, really, really good hemostasis. I know Adam had mentioned around outpatient procedures and things. This is a procedure that at 1 and 2 levels I do as an outpatient, and I have a protocol around that in terms of how long patients stay and sort of what they have to do. In closing, or in getting close to finishing here with this talk, I'll talk a little bit about some of the concepts around as the indications expand. So, as we've gotten better at doing cervical disc replacement, we've also started to get better at maybe using the arthroplasty and things that it wasn't traditionally specifically indicated for. So patients who may have what looks like some sagittal malalignment, like you see with this patient, and can an arthroplasty like this, be successful? And what we found, at least in a systematic review, and also compared it to our own patients, was that when we looked at a single level, traditional ACDF, standalone ACDF, which means an integrated device and no plate, or a cervical disc replacement, there was not really a significant difference post-operatively in terms of that C2 to C7 Cobb angle. So alignment after single level ACDF in terms of what we achieve is probably more just based on how you do your surgery as opposed to the implant itself. And so I thought that was something interesting. Myelopathy treatment with cervical disc arthroplasty, I think this was an area of some controversy, although I think now most of us would say that this is a safe alternative in terms of doing myelopathy surgery, although not exactly the purpose of this talk. But you can see here a patient with two disc herniations, central cord compression, probably a little bit of loss of lordosis, mostly based on the cord compression, who underwent a 2-level cervical disc arthroplasty. And we looked at this in terms of the effect of myelopathy on early clinical improvement and compared again our patient cohort against the national cohort. And we found pretty equivalent results, which showed that patients with myelopathy didn't improve quite as quickly as patients who had non-myelopathy complaints, but by 6 weeks, they were as good and improved in their preoperative complaints. Degenerative disc disease, I think, is obviously a topic of controversy in terms of treatment. Should you be doing surgery at all in these patients who come in with a collapsed disc and all neck pain? And it was funny because when I trained with Henry Bowman, he was very against back pain surgery, but he was always would joke and say neck pain surgery is totally different than back pain surgery. Neck pain surgery works. I'm not so sure about that. I think he just liked doing surgery on the cervical spine. But I will say that, oftentimes you'll see a patient such as this image here who's got, 2 very collapsed discs and loss of lordosis across that segment and primarily neck pain and we try to figure out, we try to call something radiculopathy around the shoulder blades and things like that. But I think most of us would agree that if you're going to do surgery on this patient, it's really for neck pain. This is a very collapsed disc. You know it's going to be spondylotic. It's going to be a challenging disc replacement. And a lot of people, I can tell you, one of my partners, where Adam trained with Todd Albert, he would, every time we have a patient like this that's presented at conference, he's like, it is malpractice to get to do, in a joking manner, to do disc replacement on a patient like this, because, he wouldn't do it. You can see here, again, not a lot of compression. So this is a very controversial patient to do surgery at all, and especially disc replacement surgery. And I certainly don't want the residents or fellows on this talk to think that they should do a surgery like this, especially during the boards collection. And you want to really make sure that you talk to the patient about how they're going to do. But I did do a disc arthroplasty on this patient. We've gotten a little bit more knowledgeable on which patients are going to do well. But in a patient like that, you really have to look at your radiographs, because there is what we looked at sort of and published on the impact of that preoperative arthrosis and what it does to the implant position. It is very difficult to make sure that you maintain good landmarks and place a good implant here. There is that surgery is a true reconstruction of that disc level, similar to what you might do in a very arthritic knee. And what we found here was that you've got to know, what your uncovertebral joints look like. And if you don't know that there is a tremendous amount of uncovertebral joint resection that's going to need to be done, that's a patient that'll have probably a negative outcome. And achieving good implant positioning, we found, was that the tighter the disc space was, the harder it was to get a good implant placed. And I think that's mostly because you have to spend a lot of time releasing all of the, not only the PLL, which we all release, but really releasing the lateral annulus and the structures that have contracted around the uncovertebral joints. And then the overall positioning, we created a scoring system around the AP and lateral fluoroscopy, and what it looked like does impact the outcome. I'll finish just a little bit with the complications, and I think there's some complications that are consistent across surgeries, but I'll highlight some of the complications that I think are particular to some implants around disc replacement. I don't have any bias as far any commercial bias in terms of a relationship with any with a company around cervical disc arthroplasty. This was an implant that I used called the Mobi-C very, very commonly because, again, it was indicated for 2 levels. I like that. It had the first FDA approval. It was easy to put in, and you can judge rotational implant positioning on a lateral image, which I really liked. But it is an unstable implant. I'm sure all the spine surgeons on this call are familiar with a lumbar implant called Charité, which is no longer on the market. And it sort of has a lot of qualities that are similar. And what I found over time as I did more of these was that there was a level of instability and prosthesis motion, even if you left the OR with what you thought was a really good surgery, that could be very unpredictable. So you could see here, subsidence and sort of unilateral collapse of this implant. This is a patient who came in at 1 year post-op, and they had complaints of neck pain, and we got an X-ray, and this is what we saw. So these do have an impact, and you can see the difference here in terms of where we left the operating room and how slowly over time where this ended up at 1 year. Here's a patient who, we listed this under infection only because when I swabbed the patient intraoperatively for when I did the revision, this is a different case. They had staph epidermidis. I'm sure that was just a skin contaminant, but I think that this was an implant problem. But this is a patient at 2 weeks post-op. So this is the intraop image of the cervical disc arthroplasty. Here's the 2-week image where you could see maybe a little bit of a change from the pre-op positioning. And then here's the 6-week post-op image. So this patient came into me and had no symptoms. He was asymptomatic. Doc, I'm feeling good. Can I go back to overhead lifting? And as I'm having the conversation with him, hey, you're 6 weeks out. You're feeling great. I think it should be fine. As I pull up the X-ray, and I'm like, change of plans. I need to admit you right now, and we have to go back to the operating room. These are just some of the intraoperative photos of that, of kind of removing the prosthesis. I did an ACDF here. So, the salvage strategy, which often people talk about maybe having to do a corpectomy or things like that. I think with most of the implants now, the salvage strategy, even for a catastrophic complication, I didn't include the CT images, but although it looked like a lot of bone loss anteriorly on that, on the inferior end plate, that was unilateral, and I was able to do an ACDF. So, take home message here, I think cervical disc replacement, at least in my opinion, is the treatment of choice for patients who have 1 or 2 level cervical disc disease without facet arthritis. I think the technique is really, really important. You have to include a meticulous decompression, and you have to have an understanding of how you're placing this implant and what are the steps that you're taking up to that point, because there are certain things that you could do that are sort of like okay, well, now we can't do a disc replacement anymore, specifically around the umbilical joint and what you're doing with the end plate. The indications, although they're expanding, you have to make sense of them, right? So even that patient that I talked about with that you're doing surgery for neck pain, you're going to do those surgeries sometimes, and you have to have a really good conversation around the patient and with yourself around what are the goals of the surgery and what is your surgery going to mean for short and long-term results. And then positioning and what kind of implant you're using. Have an understanding of the implant that you're using. Not all implants behave the same way. They're not all made the same way. And there are certain patients in certain areas, certain slopes that you need to look at in alignment where you may want a more stable implant, and you want to understand those implant properties when you're thinking about cervical dysarthroplasty. I'll stop there. Thank you.
I tell you, that's a great talk, Sheeraz. I really appreciate a couple of things about that in particular. One is that the amount of emphasis and time you put in your practice talking about value. I think that's one of the things as orthopedists we don't do a very good job at, and there's no question I don't do as good a job at that. But your effort in getting that literature out there is important, because I think that's going to be a big part of insurance and patients and what outcomes are. The second thing I appreciate is really the complications that you sort of put out there, what the complications are. What in your practice, what percentage is 1 and 2 level? I feel like 1 is already challenging enough for me, but 2 is really daunting. So what's your sort of thoughts on 1 and 2 level disc replacements in your practice?
Yeah, that's a great question. Yeah, as I've started to do more foraminotomies, Frank, most of my arthroplasties, I would say now, are 2 level arthroplasties, unless I'm treating a patient for single level myelopathy from a large disc herniation. And I think because the comparisons have primarily focused on single level, the differences, although still present, are smaller. But a lot of the studies have shown that, at multiple levels, to, sort of being the most levels that are at least FDA approved, the differences, both short and long term, can be greater. And so in my practice, I would say I probably do more 2 level cervical disc replacements than I do 1 level cervical disc replacements right now. But that, I think it's more just a function of my practice, and I like doing foraminotomies often for a lot of patients who might get an anterior surgery otherwise for 1 level.
Yeah, I just want to echo Frank's opinions on the talk. I think it hit all the major points. I think one of the challenges for CDR is that it is perhaps supplanting or replacing a procedure that's historically pretty good. Take, for example, as counter-distinction, intramedullary nailing for long bone fractures, right? That was revolutionary, right? Traction versus plates and screws, big open surgery. So I think cervical disc replacement adoption, we're talking about very fine differences in outcome. And I agree that for 2 level disease, the results are compelling. 1 level, I tell the residents, they're pretty equivalent between an ACDF and a CDR. 2 level is really where some of the differences came out, and you touched upon that. So in speaking about wider spread adoption, I think the technical aspects of the procedure are much less forgiving, like you say. So it'll be interesting to see as we expand cervical disc replacements, maybe outside of the academic setting, the more complications we see, and they can be challenging complications. A 2-level unstable cervical disc is a bit of a pain to deal with, you know, just because you're ripping 2 out and doing an ACG. So I don't know if it was more of a statement than a question. You know, I guess it just speaks to where do you see cervical disc replacement going in terms of utilization over the next 5 and 10 years?
Yeah, I think it's a really important point, Adam. So when I have the conversation with my patients, you know, I say cervical disc replacement. I think when we weren't around when it was first being, thought about, but but as taking care of patients now, you sort of say, well, I'm going to do it because I'm going to preserve motion, and that's going to reduce your adjacent segment disease, right? We can argue that every day of the week. There is probably no difference because how you're setting your center of rotation with the cervical disc replacement, it's not anatomic. And so could it be? It could be, but it's very theoretical. So I tell my patients the biggest difference is that there's no way that you could get a pseudoarthrosis, right? And and to me, both at 1 and 2 level, if you're an appropriate candidate, and the reason that I would have it done on myself is because I think that pseudoarthrosis rate is underreported a little bit, and the studies that have been done around cervical disc replacement, obviously with bias in them, have shown that the pseudoarthrosis rate for even a single level ACDF can be significant, and is probably the most common reason that patients have a second surgery. I think in terms of adoption, you know, it's an interesting thing because as much as we hate to think about this, like, you get paid less to do a cervical disc replacement, right? I mean, so whether you're paid by RVUs or whether you're paid by insurance reimbursement or whatnot, at some point, you know, if it would be interesting if sort of the system changed and we were paid based on the problem that we took care of, right? That you were in a real, like, kind of value-based system, maybe like Virginia Mason in Seattle or something, where it's like, hey, you're getting paid to take care of this person with cervical disc disease, whether you're treating the non-operatively, operatively, you're doing a foraminotomy, a disc replacement, an ACDF. Here's your piece of the pie, and you figure out what the right thing to do is. And if you do a good job, you know, more patients will come back to you, and you'll keep more of the money because you're going to spend less. So, and that's where I think, also going back to Frank's point, you know, understanding the value and the cost effectiveness, not only in the short term, because insurance and companies probably only care about this for a year or 2 years, right? They don't, I mean, the whole reason around 2-year data, I think, is from that. We care about it in the longer term, and, you know, for our patients, and because we're in this for a longer time. And so I think that's where the adoption, I think, ultimately, if it starts to come from patient and insurance demand, if we're really believing that there is a value here that could be greater, even though the clinical effectiveness, like you said, is probably similar, you know, that may ultimately increase adoption. But I do worry that, you know, oftentimes, especially out in the regular world outside of academics, that a lot of these decisions are based on, well, I get paid more to put a plate and a graft in, and I can do it faster, it's more predictable. Why wouldn't I do it?
So Sheeraz, fantastic talk. Thank you. What are the struggles with insurance companies right now? Because anytime you bring in a new implant that's probably more expensive, and there's a very reliable procedure that has good outcomes that is less expensive, what are your battles been here from an insurance and reimbursement standpoint? Because I'm sure it's not easy to get these approved.
No, and I would say that even, you know, just 5 years ago, like, every disc replacement, you were expecting a denial, you know, for a cervical spine. You were expecting a denial, and you'd have to, you know, again, a reason why, you know, guys in private practice may say, well, I'm not dealing with that. I don't want to, like, have to, like, put another burden on my office or myself, having to do peer-to-peer and things like that. I will say that one of the pleasant things has been that as the literature has supported, the value of cervical disc replacement, I don't find, and I'd be curious to hear from Adam, Frank, Hamid, the guys on the call, I don't find that these cervical disc arthroplasty surgery is really denied anymore, as long as otherwise clinical criteria are met, with radiculopathy or myelopathy. And I think that that's been a really pleasant surprise. The reimbursement, though, has been cut. The code is, it's a single code operation and things like that. And so I think, through our societies, through NAS, through AAOS, AANS, and some combined efforts, what we're trying to do is to say, hey, disc replacement, ACDF, they should be reimbursed the same. And that doesn't mean reimburse us less for ACDF. It means reimburse us more for disc replacement. And that's still to be determined. So the approval part of it has gotten easier, I would say. Reimbursement, though, has gotten worse.
Sheeraz, great talk. Thanks so much. Quick question. What do you see in regards to change in motion dynamic over the years? Do you see any difference from a day one or first 3 weeks versus 2 or 3 years post-op?
Yeah, I mean, so it's a really good question, because ultimately, if you're doing a motion preserving surgery, what you should really be interested in is, have you preserved motion at the level that you've done the disc replacement, and how it's impacted the areas above and below. And I would say it's probably like the worst studied part of cervical disc replacement, right? And so I think that so we actually submitted for a CSRS grant to look specifically at that, because we have a great kinematics lab here at HSS, and I would say the answer to your question is, I don't know. I will say just anecdotally that patients seem to be able to do better in some of the things, like getting their car out of a driveway and having to rotate the neck way over their shoulder. That's the part with ACDF, especially at 2 level, that I find that patients lose a little motion in. Most patients don't complain about the flexion extension issues as much. So, but I think, we need sort of real live patients to have some kinematic studies done to really get an understanding of if there's really, motion that's occurring that's more close to anatomic through a disc replacement, not only at the level of surgery, but also at the adjacent levels as patients get for, a year or 2 years out from disc arthroplasty.
We're at the end of the hour. Why don't we take a couple
Hey, Adam,
minutes?
can I ask a quick question?
Yeah, sure. I'm sorry.
It's great. It's Sheeraz, Dave Weiss, one of the orthopedic trauma surgeons here. Thanks. Really interesting talk. As a non-spine surgeon, I'm still very interested in the topic. Just a good presentation. I had a question. When we talk to patients about fusion versus joint replacement, say in the ankle, I don't do ankle arthroplasty, or foot and ankle surgeons do, but if I talk to someone that maybe was thinking about a fusion versus an arthroplasty and trying to decide where to send them, you always say, well, replacement can maybe preserve motion, but then you got to take care of it. It's an artificial joint. You got to, it's something different for the rest of your life. And so if you're looking at someone who's in their 50s and they're looking at, say, a disc replacement versus a fusion, versus once it's fused, it's kind of fused. You have that conversation about sort of, do they have to sort of take care of this now for the rest of their life? Is there some additional thing that they have to sort of think about going forward, whether it's dental work or whether it's just sort of thinking about the fact that you've got to really care for this joint, as opposed to fusion, where we kind of think of those as being more solid. Once they're fused, they're kind of fused.
Yeah, it's a good question. And I think that early on with cervical disc replacement, sort of there was a lot of thought around like where and sort of what can you do, what can't you do. As we've learned more and have had longer follow-up with large amounts of patients with cervical disc replacement, what we found is that, it's different than an ankle or a knee in the sense that there's so much coupled motion in the cervical spine. And even at the level that you're replacing, you still have 2 facet joints there that are still involved in movement, that the arthroplasty in the cervical spine at 1 or even 2 levels doesn't wear at a similar pattern as like a large joint might, including the ankle. So in that sense, we feel pretty good about it that like, hey, once we put this in, even if you're 35 years old, the wear part of this shouldn't be an issue as long as it's well done and we understand it. Shouldn't be. We don't know that definitively. It could be, but it shouldn't be. In terms of like how aggressive you could be afterwards in terms of activity and taking care of it from that sense, in the National Football League, if you have a disc replacement, you're not coming back. And if you have an ACDF, you can. And I would say most of that is just because of a fear of something happening around the implant that is probably it hasn't really been borne out, but could happen. We just had this debate at one of our national meetings where there is now cervical disc replacement implants and somebody in the National Hockey League and in Major League Baseball and other sports. So the NFL is probably that last sport, but I will say that in the military where guys are jumping out of airplanes, cervical disc replacement had, and I think still is, sort of the treatment of choice because you don't have to wait for fusion or something like that. So as far as the load that it can take seems to be pretty, that it can tolerate pretty high loads.
Great, thank you.
Hey, Sheeraz, a very good talk. I learned a lot. Josh Lee here.
Hi, Josh.
I like the disc replacement very much, and right now I expand the indication a little bit. 4 weeks ago, I did a surgery for a young patient with a collapsed disc in the 2 level, 3 millimeter disc height. So I put in the 5 millimeter of the implant, and the patient complained about neck pain for about 2 weeks, and then the pain goes away. And what's your thought, experience on the disc height, collapsed disc? What do you have any cutoff for the disc height?
I don't. My partners will use 50% as their cutoff, and I think that that's probably what's most commonly used. I am a little bit more aggressive, I would say, in terms of saying, if it's really purely disc height loss, but the uncovertebral joints look reasonable to me, that I think I could release them without destabilizing, then I will still do it. And I think the patient that you're describing, I actually tell my patients if I'm doing a collapsed disc that their neck pain can get worse before it gets better. And I think a lot of that is from the facet capsule. So, sometimes these patients don't have facet arthritis, but they've got contracted facet capsules. And when you're distracting the disc, you're also distracting or trying to open up the facet capsule. And I think that can generate pain because that capsule has been contracted for so long around that joint. And so I often will tell those patients that the back of your neck is going to hurt for a few weeks. And it's really important to start to move early in those patients to start to introduce movement and that pain. Now that I'm going to say this, I'm sure today in my office, I'm going to see somebody who's got persistent pain, but I haven't had a patient in that scenario who's had pain like beyond a month, which is what I usually tell them it's going to be about.
Great. Do you do any hybrid implant?
I don't, unless I'm doing it above an already fused level. So if there's a C6-7 fusion that was done a long time ago and now a person comes back and has a soft disc herniation at C5-6, I will do a hybrid. The reason I don't do hybrids like from the start is because I think it's a rare scenario where one level doesn't fit the criteria for a disc replacement, but another one does. I just haven't found that patient because I'm like, well, if this level's got facet arthritis and a lot of uncovertebral hypertrophy, then that's the pathology the patient's kind of presenting with, and it usually affects both levels similarly. So instead, like I'll either do a single level ACDF or a 2-level ACDF. I have not had experience doing hybrids, but it's just I just haven't found the patient that it would be that is the right indication.
Thank you so very much.
Yeah, of course.
I think the feedback has been
Can I ask a question?
phenomenal. I was going to try to move along just in the interest of time. Charles, do you mind just starting your second talk?
Yeah, let me.
Dr. Adam, can I ask just a question before?
Sure.
Of course.
Yeah, so that was a great talk, Dr. Qureshi. I'm the spine fellow here, and I did an observership with you for 2 weeks in New York.
Hey, how you doing? It's good seeing you.
Good to see you again. Just a question about the adjacent segment disease. Does the doing disc replacement change your implant choice for adjacent segment disease? Cervical disc.
Say that. So does the
Does the presence of cervical disc replacement change your implant choice in the future for adjacent segment?
Oh, that's a good question. You know, I think again that's something that we haven't looked at as much, and I, you know, it's a really good question because I will say I haven't had the scenario where a patient has had a disc replacement, at least that I've done and that I could think of, coming from elsewhere, where they've had an issue at the next level, and I think it's probably just it's coming. You know, we just I probably just haven't done them for long enough just yet, and I think it probably would, and I would say that if there's like, you know, keeled implant, let's say at 2 levels, you know, maybe that 3rd level, if I'm going to do, I might consider doing a non-keeled implant if I'm doing it above. Maybe which level is involved. If the patient's had a C5, 6 disc replacement, now the issue is at C6, 7, and they've got a lot of lordosis along that level, I may choose to do something that is more constrained with a keel. So I think it would be patient by patient, but I think it would be something that you would have to keep, you know, sort of think about and be thoughtful about in the treatment options if you're seeing somebody for an adjacent level issue next to a cervical disc arthroplasty.
Thank you so much.
A quick, just a comment, Sheeraz, sorry to interrupt, but I just, residents, faculty, PAs, I have a special presentation for one of our residents after this next talk. So please stay on the line for just 2 minutes after Dr. Qureshi's done. Go ahead, Sheeraz.
All right. Thank you so much. So this talk, my next talk will be sort of around minimally invasive T-lift surgery. You know, as Adam had mentioned, my practice really focuses in the lumbar spine on minimally invasive procedures that I've been doing for quite some time now. And I think you know, it's sort of an evolution in practice. Like Adam, you know, the fellowship that I did, the M in MIS did for maximum. And as more and more patients demand minimally invasive procedures and as technology has advanced, I think for most of us, it's become an important part of our practices. Let's see if I could find my cursor here to try to advance this talk. There we go. So I do have some relevant disclosures for this one. I do some consulting and have some royalty with a company with Globus who, and I'll be speaking about their robot. So I think with minimally invasive surgery, especially around spine surgery, as most, I think the spine surgeons and the non-spine surgeons on this call would say, well, what is it? You know, what's the definition? And I would say that there's definitely a spectrum of invasiveness, non-invasive being on one end, maximally invasive or kind of traditional open spine surgery on one end. And then minimally invasive tends to be this like big black box of a bunch of different things that are probably most often used as marketing tools as opposed to actual surgical tools. So I think we know what non-invasive is, right? A needle biopsy, you know, something that doesn't really cause any collateral tissue damage would be considered non-invasive. And then I don't like to use the term maximal, but, you know, we'll use it for the purposes of this talk. But, you know, traditional open surgery, you know, where you've got to, you know, cut the muscle or at least detach the muscle and retract on it, we'll call sort of, you know, the collateral tissue damage that happens. And then minimally invasive which was a term that was coined in Britain several decades ago now, is really, procedures where you're minimizing kind of the damage at the point of entrance to where you're trying to get to. And we think about endoscopic procedures, laparoscopic procedures, arthroscopic procedures. So, but in the spine, it's a little bit less defined. And I would say when we think about minimally invasive surgery, probably the worst thing to happen to minimally invasive spine surgery in many ways was the Laser Spine Institute. We probably all remember advertisements such as this one in airplane magazines where, they showed a picture of like a thin person in a beautiful area, with a small bandage. And I would say that this has done more harm for minimally invasive surgery than good. The reality is minimally invasive surgery really, can help all of our patients, the elderly, the obese, and also the thin and the beautiful. So the naysayers, I think would question the clinical effectiveness. They would say that the results might be harder to reproduce in everybody's hands, that the complications are underreported, and then that, kind of everybody uses the term minimally invasive because that's what patients want to hear. And I'm hoping that at the end of this talk, you'll sort of find that, the adoption of minimally invasive techniques it really pushes us towards improved efficiency and outcomes and ultimately better patient care. And the one thing that I would say is that, hopefully what you'll take out of this, especially for the residents and fellows on this call, is that when you get into practice, you can read the literature, which you should, and you should use that as a guide, but your patients should, and the care that you're providing should be the most important guide. So follow your patients, collect the outcomes, because what works best in your hands might be different for a particular problem than what works in others. And in spine surgery, there's a lot of ways to achieve good outcomes. So you got to figure out what works best in your hands. So the keys to success are: don't change your indications, and understand what your goals of surgery are based on why you're doing surgery. So when we think about spine surgery indications, we think about doing surgery for spinal stenosis, right? Which I'll include herniated disc in that, instability or deformity, right? And so if you're doing surgery for those reasons, then I think that you will have success regardless of how you do the surgery. And then your goals, you want to decompress, you want to stabilize, and you want to be thoughtful of the alignment that you're providing to the spine. And so if you can marry those things, then you know that you will have a better chance at having a successful result. And I would say in spine surgery, in some form or fashion, we're definitely behind the curve, compared to our partners in other surgical specialties, and even within, orthopedic surgery and neurosurgery. Having a big incision like this for cholecystectomy, is a almost never thing nowadays. Everything's done through small portals around the abdomen, and even in spine surgery, the thought of doing things less invasively is not new. If we go back to the 60s, 70s, leaders in the field have thought about how to do things less invasively. The limitation has always been the surgical technology, and that part has changed. I would say, at least for the first time that I know of, I think a lot of my partners who are senior to me would agree, the technology that's available today is ahead of what the surgeons are ready to adopt, and that is a new place to be in spine surgery, because the things that we could see both through illumination and imaging are just at another level right now, and really impacting the way that we do things. I would say in the United States, at least, the birth of minimally invasive surgery was based around percutaneous pedicle screw placement through this system called the Sextant system, which was introduced back in 2001. So it's still a relatively young field, but not that young anymore. The tools vary and have changed. So this is my sort of OR and the different tools that I use. The workhorse of minimally invasive surgery is this tubular retractor that's shown on the bottom of the screen here. I'm so sorry I can't seem to find my cursor, but I think you guys can see what I'm referring to. I think microscopic visualization is important, and then whether you're using fluoroscopy or intraoperative navigation or robotics, and I'll touch on all of these. These are all tools that we use in real time during surgery to help us with these. So in terms of the things to consider, you really want to achieve the same goals as open surgery. So you want to think back to those. Am I doing a decompression? Am I doing a fusion? What do I think? What am I doing for alignment? And a lot of us get caught up in minimizing the size of the incision, and that is sort of what it is, but it's probably really the least important part of minimally invasive surgery. It's really trying to minimize soft tissue disruption, and then ultimately how to enhance post-op recovery. So I'm going to focus on one minimally invasive procedure of the multiple that there are, because I think it's probably the one that's most often used to treat the pathology that most spine surgeons see every day. So you see a patient here who's got spinal stenosis with spondylolisthesis L4 L5. There's a facet cyst coming off of the joint on the right side at the L4-5 level. And this is a procedure that we can use at a national meeting in a debate and say, who would treat this with anterior surgery? Who would treat this with a posterior surgery? Who would just take out the cyst? Who would do a fusion? Who would do this from the side, et cetera? So this is a hotly debated issue, but for me, it really sort of highlights the workhorse procedure in minimally invasive surgery in the spine, which is the minimally invasive transforaminal lumbar interbody fusion. So what that means is, we're really trying to change sort of a big exposure where we're cutting the muscle, doing a laminectomy, exposing the neurologic structures, to doing something through percutaneous openings, smaller openings, tubular retractors, and really trying to preserve the bony structures, the muscle attachments, and the ligaments that sort of attach along the spine. What we're doing here, so just for some of the non-spine surgeons on the call, so we dock a retractor that sits on the facet joint, and then here we're in the facet joint, so we've identified our facet joint. We then go to an area called Camden's triangle. So what you're looking at here, that white structure there is the dural sac, and that one there is the disc. So we're really accessing the disc space right next to the dural sac. This video is from a few years ago. Most of the time when I do this procedure today, I don't want to see the dural sac at all. I take even a more lateral approach, and that's been part of my learning curve in this. Disc space preparation is critical. So, we want to prep the disc space as much as we can. And then if you want to add a direct decompression after the implant is placed, we can sort of, by wanding the tube and working over the dural sac, we can still do a full decompression. But what we've done here is what's outside of this tube is the spinous processes, the other half of the lamina, and all of the muscles on both sides, as well as the interspinous ligaments. If there is pathology, like I showed earlier, this is that patient whose image I showed of the facet cyst, you can have direct access to removal of that cyst as needed. So after the interbody cage is in place, you can go and deal with direct pathology. A rod is then passed through percutaneous screws. And I think that this is, the nice thing about a minimally invasive TLIF is it can be done in a lot of ways. And when I first started doing this surgery, I used live fluoroscopy. So one of the things that you see here draped in is a C-arm. And that was a critical part of my surgery, was the ability to use a C-arm. But here's just a video of multiple x-rays that are taken through a fluoroscopic surgery. And every time the picture changes, x-ray, 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 x-ray. So you can imagine there's my hands getting radiated. You're going to see my fellow's hands in a second also getting radiated right there. And so this was, a fluoroscopically based MIS TLIF, is a great operation, easy to do, and I think is the way that most people do it. But the radiation dosage to the surgeon, to the patient, to the OR team can be quite significant as you go, through the entire procedure from the start all the way down to the finish of putting in the screws and passing the rod. So you can just imagine how much X-ray is being taken there. So the other thing with X-ray is that oftentimes, you can put screws where you don't want them to. So this was a patient who's having an L5-S1 fusion done, and you can see the L5 screws are sitting right in the facet joint on the right side and have violated at least a portion of the facet joint on the left side. And so the accuracy of screw placement can also be in question when using fluoroscopic guidance alone. We looked at this, so I sort of felt this as an issue as I was going through my learning curve of MISTLIF, and so we went to a lab with some residents and fellows, and we put in percutaneous screws in a bunch of cadavers, and then we dissected the cadavers, and we found that it's pretty safe and accurate if you're thoughtful about it. But the traditional thought of placing screws at the 3 o'clock or 9 o'clock position and passing them in, when it came to percutaneous screws, we sort of defined a different way to do it, where you actually really want to start at the inferior lateral border of the pedicle. You want to aim up, and then you want to redirect your hand. So it was certainly something that could be a little technically challenging in order to prevent facet joint violation. And then again, as we talked about, a lot of radiation. So we looked at my own patients and published a study on this, looking at sort of the radiation exposure in an MISTLIF. And although, we got better after the first 50 cases, you could see that even when we were considered mature on our learning curve, one case, still had up to 2 minutes of live fluoroscopy time. And so that was pretty significant. And I thought, that was kind of eye-opening for me. It sort of started my interest in 3-dimensional intraoperative imaging modalities, and of which there are many. And this is really where the field is exploding now. So I then shifted to using navigation. I started with using sort of more traditional navigation, and then more recently shifted towards doing something called the spine mass tracker, which is a skin-based navigation where we place the tracker on the skin. You could see with navigation, so this is a setup for an MISTLIF in my practice, where the mask is sort of outside of the field. So it's at the top of the picture here, that yellow thing that's draped with Iovan. And then we can get a really good look, and you can see, so that's myself and my fellow, and you can see there's no C-arm draped in the field anymore. And we've got a really good 3D view of exactly where that first Jamshidi needle, it's called, is going. And I think it's a great teaching tool because, we can really do this surgery together, and the fellow or the resident can have a really good look at exactly what they're feeling and what's that's translating to on a screen. In terms of being able to, accurately place pedicle screws in areas that are traditionally difficult to visualize, even on with X-ray, such as the sacrum, and getting towards good medialization and towards the sacral promontory, I think that there are advantages. And then working around large facet joints, such as is shown here, in order to get an accurately placed screw in a good position with the longest screw possible. I think there are definite benefits to this 3D imaging. I use it for docking my tubular retractor as well, and I think that allows for accuracy and just a good understanding of where where you are right away. We looked at this, and this is a study that was published in the Spine Journal, just looking at the total time demand, because I would say that, when I talk to my partners who now are, I would say, thankfully, all believers, the biggest thing was, wow, I don't have time for that. I got too many cases to do. It takes too long. And what we found was that, the time demand difference from fluoroscopy versus navigation, the difference was only 5 minutes. And it was statistically significant, but I think 5 minutes is a pretty small amount of time, and less than what I thought it would have been. And worthwhile, especially when you think about the total radiation dose. So you see the fluoroscopy time in seconds. You can see this is extremely significant in terms of having 26 seconds of live fluoroscopy time. And the total radiation dose, is statistically significantly different. It's still higher than what we want it to be, but remember, part of this is the spin that we can all step away from. And doing these surgeries several times a day, several times a week, a month, a year, that radiation dose, can add up. And then ultimately and importantly, what about the pedicle screw violation, like we showed earlier, where you violate the facet joint? And that violation, you can see in this regression analysis that, with fluoroscopy compared to navigation, you have twice the odds of a poor screw placement. And poor screw placement here is specifically, kind of looking at that facet joint violation. Some other issues that I've sort of gone through, so this is a patient of mine, I think this was my first or second MIST lift, and I think I did everything wrong. The patient did fine, but you can see a broken guide wire. At that time we were using stainless steel guide wires. You can see a really small implant in the inner body space. And I'm sure if we looked at the lateral image, which I don't have here, but it would show, that the person is pretty flat backed and things. So, you want to think about all of the goals of this. So, one of the things that I always hear about, in terms of minimally invasive T-lift surgery specifically versus traditional open surgery is, well, the fusion, how do you get a fusion? And I would say that, again, I've gone through the learning curve. This is not one of my patients, but a patient that, I saw a few years ago who had a minimally invasive surgery done elsewhere, who clearly, has a significant pseudoarthrosis, screw loosening, et cetera. And it sort of led me to sort of say, boy, how am I doing in this? And when I thought about, sort of the different ways to achieve fusion, there's allograft and infuse and autograft and different implant types. And I went back and I looked at my own patients, and this is data that we published. I think it finally got published just a couple of years ago, but we weren't doing that great either. My fusion rates with kind of just allograft type bone material was less than 70%, and my fusion rate using infuse was better, but it was still under 80%. And then the complications of infuse, sometimes they are symptomatic, sometimes they're not, but this is a common one, neuroforaminal bone growth. So maybe we were increasing our fusion rate, but was that really helping our patient? And so sometimes you look at your own data and you realize you've got to go back. You got to think back. And I thought back to my fellowship, and I thought back to Henry Bowman and how we would take iliac crest autograft for everybody. And so I went back to taking crest graft, and that small incision there, is I figured out a way to use navigation and to do a minimally invasive approach where we didn't split any muscle. We'd made a percutaneous opening over the top of the crest. And then we passed this reverse reamer that I think is often used by people in trauma and in hand surgery, and reamed from between the tables a large amount of autograft bone, and then used it with different options. This was a minimally invasive disc prep instrument set that I had developed to help get really nicely across the midline and really do a larger disc prep. And then when we went back and looked at our fusion rates, we found that if we combined iliac crest autograft bone with some newer cage technology, as we'll talk about, our fusion rates finally went above 90%. And this was all CTs at 1 year, looking at fusion and comparing them in each of the groups. What about alignment? A lot of times with single level surgery, we don't really think about alignment. We say, well, that this is not a deformity, right? I mean, this is like, this person's fine. And this has been looked at by a lot of authors. One of my partners, Todd Albert, when he was at the Rothman Institute, looked at this, and even at a single level, lordosis reconstruction is important. And I think what we're finding is it's not only important for what the X-ray looks like, but it does have an impact on outcomes. And one of the things that we always think about, and we always talk about with our patients, is around, what does a fusion mean to the adjacent segments and the degeneration that occurs. And I think reconstructing optimal lordosis can potentially help in that. And I think we're going to show that with time. So here's that same patient that I'm talking about. I think I had a pretty good result in the translational reduction of that spondylolisthesis. But I would say that if we really looked at the lordosis, if somebody said, well, I could do a better job than that if I did an A-lift surgery, or if I did an open surgery, because not only would I be able to get the translational correction, but I would be able to really get the lordosis better than what you got it there. It's hard to argue that. And what that ultimately means in this patient for their next disc, L4, L5, time is going to tell. But certainly it made me start to think about, what can I be doing in my own practice to sort of do better with this? So the first thing we did was, we did a systematic review to see what's the literature out there on lordosis reconstruction with MIST lift. And we found there's not much. So then we did our own study on this that was published a couple of years ago in one of the neurosurgery journals. And we found that you can control it. You have to think about what the patient's got going in. It's a very busy slide, but really the basis of the information here is that by using certain types of cage technology, especially expandable cages, you can start to improve the amount of lordosis that you can restore, but it does depend on how much lordosis the patient already has going in. So here's a patient, collapsed disc, little loss of lordosis, not terrible, but we used an expandable cage. We got it placed anteriorly in the disc space, and that expandable cage allowed not only for restoration of the posterior disc height, but also improvement, at least in the lordosis, even if slight here, but we're not making that worse, certainly. But expandable cages alone won't do the trick, right? I mean, here's a patient similar to the other one that I showed that I did use an expandable cage, but that's where I got it to. And you can see, again, the lordosis probably not optimal. Better, but not optimal. And so this was a paper that we recently published that looked at sort of the most important factor is not the amount of lordosis the cage is necessarily giving. We say, oh, well, let me use a 15-degree cage or a 10-degree cage or a 6-degree cage. Those are sort of small differences, but really the most important thing is where you're getting that cage in the disc space, and getting it into that anterior third of the disc space, into the front of the disc space, is really the most important thing when we think about lordosis. And now that we've, sort of make a conscious effort to do that, I would say that we've gotten much better at the type of lordotic alignment we can get. And you can see here the pre and the post-op, you can really get good lordosis reconstruction here, and everything's being done through the interbody space. So for some of the non-spine surgeons on the call, when an open surgery is done, you can put these cages in, and then you can use your screws to compress across and get lordosis. That doesn't happen, unfortunately, in minimally invasive surgery, despite what your reps might tell you. I think the guys on the call would agree. Percutaneous screws, you just can't do that. Here's another case of a patient who, had a 2-level issue. And you can see if we can get the implant anteriorly, we can really get good lordosis reconstruction, and as well as getting good posterior disc height reconstruction without compromising the two things. Doesn't always go well. So this is a patient, one of my complications, L4-5 spondylolisthesis, happens to be a family member of a spine surgeon I know, sort of what you would say home run operation, L4-5 spinal spondylolisthesis. But as I look back on it, I'm like, oh boy, tall disc. I didn't really check the guy's bone density. Screws are really small that I used, and that cage is not, even at fully expanded, is still barely touching the end plates. And this is the patient at 6 weeks post-op. You can see loss of the reduction, subsidence of the cage. And I would say it's really, really important to sort of, even when you think you're good at this, seeing your patients back can be very humbling. And this patient, pretty much all of his symptoms came back. Now we looked at this, so this led us to, I wondered, well, how often does this happen? Is it really meaningful, or is it a one-off? And so we've looked at this recently. This is data that's submitted for publication, but is in revision right now. But what we found was that patients with subsidence tend to be a little older. They definitely have lower bone quality, which is why getting a sense of bone density is very important. The larger the implant footprint is, the less likely they're to subside. So filling that disc space becomes really important. And clinically, whether it's meaningful or not, I would say, again, even though our data suggests that it may not be very clinically meaningful, I still think that, even if you see one patient where they didn't have a good outcome, like, if you could do a better job, it's worth following. So there was no difference in fusion rates that we found. But, in the SF-12 physical function score at 1 year, there was a significant difference in patients who had subsidence. There's some technical challenges around using some of these kinds of cages that can provide the lordosis, that can have a big footprint. Here's a patient who just had this was a 3rd time recurrent disc, collapsed disc. We did a MISSG lift, and you can see on that AP X-ray, that cage did not go where, lateral looks okay, but on the AP, it did not get where it needed to. And this is what it looked like on the CT scan. And I ultimately had to reposition this cage because it was irritating. He had some neurologic symptoms, and I wasn't convinced it wasn't from that. We've gotten better again with technology as far as this goes. So I think this is where robotics plays a role in my practice. I've sort of again, I have a commercial bias here in just a sense of the fact that I consult and get some royalty from a company who makes this robot. But I would say I am 100% in on robotics when it comes to spine surgery. I think we think about it mostly with screw placement, but I think we all place screws pretty well. I think the three-dimensional aspect of navigation married with the precision of robotics allows us to place it better. But I think really, planning this case, so this is just a picture of me with one of my fellows in the OR. We're doing an intraoperative plan and then placing 4 screws. The clock is there, so you could see doing the intraoperative planning and then placing the 4 screws. So that's from the first picture over to the third picture. Doesn't take a lot of time. This is just, a single level, so 4 screws. But what it does do is it really allows us to map out the perfect screw for each patient. So I found myself, I generally, 6'5" 45" was my screw of choice. And now I really choose the screw that fits the pedicle the best. Sometimes that's an 8'5", sometimes it's a 60, sometimes it is a 6'5" by 45. The other thing that it allows me to do is sort of accurately kind of position some of my disc prep implants. So this is just showing the screw placement, but here's the disc prep. You can see I'm looking up at the screen there. So I've got a curette in the disc base, but I've planned out where my inner body is going to be. And so I can really prep by seeing that overlay on the screen where my curette is. So I'm making sure that I'm prepping where my inner body ultimately will go, and then ultimately placing the inner body using that navigation guidance so I can watch exactly where the inner body goes in 3 dimensions to avoid a scenario like I had shown earlier where the implant, was too lateral in the disc space. In terms of MIST lift surgery, I think the biggest advantage here, the thought is always like, okay, it's great, but like, so what? What does it really mean to the patient? Maybe they get out of the hospital a day earlier, maybe they go home the same day. But really, does it matter at the end? And I would say that, the more we're looking at this and the better we're getting at it, we're finding that, for things that are important to patients, when can I go back to driving? When can I go back to work? When do I not need pain medication for here? So here's our data here, again, submitted for publication, but not published yet. But what we found is that, patients who have a single level fusion versus patients who have a single level decompression, you can see that single level fusion, the differences are not that great. So in terms of return to driving, a single level decompression, we found in our average median days in our cohort was 14 days. The fusion went back at 18. In terms of returning to work, difference of 12 days. And in terms of getting off narcotics, difference of just a few days. So, I think hopefully valuable information that we could know for ourselves and provide to our patients. Sorry, I'll go back here, but so I'll finish off with the case, and sort of to highlight kind of, what we're hoping to achieve. So the patient, you'll hear him, but he's got essentially symptoms of neurogenic claudication or radiculopathy.
In the right leg, numbness in the right leg in the calf for the past 12 years, and pain in the lower left side of my lower back also.
Any weakness?
No weakness.
Have any injections or physical therapy helped?
Absolutely not.
Thank you very much.
All right, so you can see L4 5 stenosis, spondylolisthesis, sort of a classic patient that we are all going to take care of many, many times a year. We did a single level MIST lift on this patient. What everybody high fives about is the little incisions, but that really doesn't matter. I would say it's the least important part of it. But what is great is that, this is our, part of our outpatient protocol. So this is 5 hours after surgery. We have them up and walking.
What time in the right leg? Just the incision from the back. I have never felt this good in 12 years.
So I think, when done appropriately, obviously in collaboration with our anesthesia colleagues, we're doing some specific blocks and things like that, but starting to think about, and doing outpatient single level fusion surgery, I think is becoming more of a reality. And I think that's where these techniques will really allow us to get to as we continue to move forward. So take home points, I would say in general, minimally invasive techniques are safe and effective for the same problems that we deal with open surgery. I specifically use the term degenerative deformity here because I do not believe that minimally invasive techniques are a good option right now for real deformity surgery. I would say for the residents and fellows, the spine surgery is, a very discretionary surgery, right? A lot of ways to do it. So, and a lot of times when you should or shouldn't do it. And the art of spine surgery, like any surgery, but really, I think in spine surgery, it's so important is the indication. That's the art. And use technology, but use it on real pathology. Don't let the technology drive your surgery. Let the surgery drive what kind of technology you use, and never compromise on the goals of surgery. Don't do a worse surgery just because you can use technology. You gotta focus on what the goals of surgery are. Make sure you get them done. That's how you're gonna have happy patients. Thank you.
Shiraz, quick question. Do you have any limitation in the patient size? I feel really difficult in MIS when you go above 90 millimeter with the tubular lengths, and the triangulation becomes very difficult, and the safety becomes compromised. What do you do? Or you guys don't have any in New York?
I was gonna say, I think one of the good things is, with where I practice, it's rare for me to have to need a tube that's 90 millimeters. But we're often in a 70 millimeter tube. I do think that there are some limitations when it comes to size, where it makes the surgery a little bit more difficult. Triangulation becomes a little more difficult. Can the burr reach all the way down to where you need to get to becomes difficult. So there are advantages and disadvantages. When you get done with that case and you're closing still 4 or 5 little openings, as opposed to a giant incision in a person who has a large BMI, I think that's a real positive, but it's a much more difficult surgery. And I talk to my friends in Chicago who deal with or in the Midwest who deal with these much bigger patients on a regular basis. And I think, like anything else, there's a learning curve to that. And you sometimes need special instruments. I think one of the things that I'll do sometimes is I'll make a bigger skin incision and then just drop it and then make the fascial opening sort of separate. So I'll put like a little Wheatlander on the skin, and then I'll make the fascial opening and I'll just drop like a 70 millimeter or 60 millimeter tube still. And then this way, it's just a skin opening that's a little bigger, but I'm still working in a tube that I'm comfortable with. But in all honesty, I will tell you that for me, one of the benefits of practicing where I do is that it tends to be a less common occurrence of having to use those big tubes.
Great, Sheeraz. I want to thank you for attending. We're getting ready to break real quick to go to clinics and ORs. So I hope you got our little gift package.
I did. Thank you so much. I loved it.
And I really appreciate you spending time this morning to educate our department. Really fascinating stuff you're doing up there. And please say hello to everyone at HSS. We obviously have a lot of contacts with your department. So thank you very much. Any other final questions? Great. Thank you. Hope we can do this in person sometime soon. And
thank you so much. Thank you. So I really had a great time. Thanks for everybody for sticking around. I know it's always hard when you got OR patients to get to and things like that. Thanks so much. It was great.
Thanks so much.
Fascinating. Fascinating. So everyone, I just want to make a quick recognize someone and make something final. Jim Burgess, you're on the line, right?
Yes, sir.
All right. This is actually a huge honor for me as a supervisor. I guess I'm supposed to make this final. Dr. Burgess has been promoted in the military. So I'm supposed to read this to make this final, and also offer congratulations from the department, Jim. So the President of the United States has reposed special trust and confidence in the patriotism, valor, fidelity, and abilities of Captain James Michael Burgess. In view of these qualities and his demonstrated potential for increased responsibility, he is therefore promoted in the United States Army to the grade of Major. So congratulations, James. Really fantastic. Obviously, your devotion to our military is incredible, and we're proud to have you as part of our department. But I guess this makes it final that you are promoted to the rank of Major once that was read. So congratulations, and I'm glad the members of our department could hear that.
Thank you, sir.
Congrats.
All right, everyone, time to break. Thanks, Spine Division, for arranging that conference. Really fascinating stuff. Obviously, spine technology is advancing quickly, but also it's very expensive. So we'll see how that plays out. But
You had to take one jab at it. You couldn't have just left it nice, right?
It's fantastic, but it's expensive. That's all I'm saying. That's all I'm saying is expensive. Looks expensive, and I'm sure it is expensive. So, but anyway, great talk. So thanks, everyone, and have a good day. And congratulations, James.